Hello, and thank you for taking the time today to review my presentation. My name is Cordero Rios, and I will be speaking with you today about my Doctor of Nursing Practice Quality Improvement Project entitled Implementation of the Ask Suicide Screening Question Toolkit for Increasing Suicide Screening in Primary Care. Before I delve into this presentation, I first want to take a moment to thank my committee members, as Dr. Petrov, my chairperson. Thank you for everything, and Dr. Snell. The purpose of this quality improvement project was to implement the Ask Suicide Screening Toolkit in a primary care facility to increase suicide screening rates among patients. The peak of clinical questions that was used to guide this project was as follows. In primary care providers, does the use of the educational program on the Ask Suicide Screening Question tool compare with the baseline increased patient suicide risk assessment for psychiatric care as documented in the electronic and medical record 4 weeks following the intervention? So the significance of this project for nursing can be seen when reviewing general data and statistics about suicide. Current evidence indicates that suicide is the 10th leading cause of death in the United States, and more than 45,000 people die of suicide, which is twice the number of people who die by homicide. Also, primary care providers may believe that suicide prevention is beyond their capability. Evidence does indicate that 50% of all patients who commit suicide visit their PCP in the month prior to their suicide attempt. Evidence also indicates that those who commit suicide, around the 83% had visited their PCP within the last year. This statistic suggests that primary care providers are an important resource for suicide prevention within the community. However, current evidence indicates that few primary care providers actively engage in the patient suicide risk screening, despite evidence-based recommendation to provide suicide screening for all patients over the age of 18. Because this quality improvement was an evidence-based intervention, a search of the literature was undertaken to identify the most relevant evidence to support the project. On this slide, I have included a detailed review of the search process. In the table 1, I have included the search terms I used for locating evidence on the topic. A total of 5 electronic article database containing research articles on healthcare of nursing were selected for searching. Limits were placed on each database containing research article on healthcare and nursing limits were placed on each search to ensure that the highest quality and most timely evidence was obtained. Limits include the following: full text article published in peer-reviewed scholar journals in the last 5 years and written in English. Search terms include primary care, education, and suicide screening. On referrals, all search terms were combined with the Boolean operator N. And synonyms were added for subsequent search to expand the search for the article. The table 1 below provides a summary of the search term from the PICOT question and the synonym used. Synonyms were combined with the Boolean operator OR. So, from the literature, 3 terms were identified, and a brief review of each is provided on this slide. The first theme was the importance of providing suicide screening in primary care regardless of the tool used. Evidence indicates that various scholars have evaluated the ISQ toolkit and other tools for providing suicide screening in primary care. So collectively, the evidence strongly supports the use of suicide screening in primary care. The second theme identified was with regard to the feasibility and effectiveness of suicide screening in primary care. Collectively, This research indicates that suicide screening was safe, low cost, and easy to implement. And for example, the final theme identified from the literature was the need for provider training and education on the suicide screening. This evidence demonstrates that implementing suicide screening could be cost-effective, simple, and easy to accomplish. So, a critique of the evidence is provided on this slide and includes an overview of the strengths, weaknesses, and limitations and gaps in the research. The strength of the evidence stems from the consistent results provided in the literature across multiple studies. Further, the consistent use of quantitative methodologies demonstrates the statistical significance of the intervention. Weakness of the literature indicates that most studies utilize small sample size that may not be generalizable. Further, many of the studies did not use control groups for comparison, limited the ability to identify a cause-effect relationship between the intervention and the outcome. Limitations of this literature search include only using 5 databases for searching, concerns over the methodological limitation of the included studies, and a lack of methodological rigor across all of the studies. Gaps in the research stem from a lack of long-term follow-up to determine if the projects are effective, and a lack of insight regarding what works best to educate providers about the suicide screening. So, the theoretical framework that was used to guide this project was the theoretical model, TTM, of change. The model is based on the idea that change can be facilitated through 5 stages. This stage includes the pre-contemplation, the contemplation, preparation, action, and maintenance. Pre-contemplation is the first stage of change and represents a state in which the individual is not actively aware of a problem or the need to change, as an effort is made to raise awareness of the need for change. The individual moves into the contemplation stage of change. During this stage, the individual is ambivalent about change but does recognize that change is needed. Motivating the individual to commit to change occurs during the third stage of the model, or preparation. Preparation involves active efforts to determine the specific action that will be taken to make a change. Preparation should lead to action, which is the 4th stage in the TTM. Action involves making the change in order to overcome the problem. Once action is taken, maintenance begins, and efforts must be made to help sustain the change over the long term. The TTM was used in the current project as a means to guide the development of the intervention, to help motivate the staff member to change, and use the ASQ toolkit as a part of a standard patient care. So, this project utilizes a quantitative experimental framework. More specifically, the design of this project utilizes a single-site quasi-experimental post-intervention approach. The sample was drawn from a single primary care site, quasi-experimental study, lack of randomization, or control group-wide, often utilizing subjects that are selected using a convenience sample. This design feature were presented in the current project. Data was collected 4 weeks before and 4 weeks following the implementation of the ASQ toolkit at the practice site. The PDSA method involved planning in the project based on the evidence, that the translation of the evidence to the practice site, implementing the intervention at the practice site or the do phase, evaluating the outcomes of the study phase, and actions to determine the next steps. So the inclusion and exclusion criteria used for this project are provided on this slide. The inclusion criteria for staff to participate in the quality improvement project were as follows: provide direct patient care, including being a physician assistant, or a past practice nurse, between the ages of 18 and 64, verbally agree to participate in the project, including in writing and spoken English, employee at the facility for at least 6 months, and employee full or part-time at the facility. Exclusion criteria for staff participation in the project were as follows: under the age of 18 or over the age of 64. Refused to verbally agree to participate in the project. Limited English proficiency and written or spoken, contract or temporary employee, and unable to screen patients for health issues. So the data collected for this project primarily focused on the retrieval of data from patient electronic health record to determine how many patients were screened for suicide risk before and following the educational program. A data collection form was developed for this project and is featured in this slide. The form required the IT staff member to parse the electronic medical record of patients seen at the practice and to tally all of the demographic and suicide screening information. Because the data was obtained from the electronic medical record, the validity and reliability of this instrument was assessed based on the literature. Scholars note that the electronic medical record is a rigorous and reliable source of data search. So, data for this project was analyzed using the statistic packet for social science. Demographic data for providers enrolled in the project was analyzed using descriptive statistics including mean, standard deviation, and frequencies. Descriptive statistics were used to assess the demographic of patients seen before and following the educational intervention. Frequencies were used to assess the total numbers of patients seen and the total number of suicide screening before and following the educational program. Inferential statistical tests, including the C-test of population proportion, was also undertaken to determine if any change in suicide screening rates was statistically significant. For this project, an alpha value of 0.05 was used for comparison. Effect size for the intervention was also calculated. The setting for this project was a primary care practice currently operating in South Florida. The practice serves the community, which includes a diverse range of population groups. The payer mix for the facility includes 50% of Medicare and Medicaid, 40% of private insurance, 10% of self-pay or TRICARE. The practice currently employs 15 physicians, 12 advanced practice nurses, and 7 physician assistants. These direct care providers were asked to voluntarily agree to participate in the project. This target population was selected because direct care providers are the clinicians who are responsible for assessing suicide risk for the patient. Although it would have been dear to enroll 34, all of 34 direct care providers, it was only possible to enroll a total of 7 provided from the practice side, which is, I really thank all of them. So patient data collected as part of this project is reviewed on this slide. The table provides an overview of the demographic characteristics of the patient seen 4 weeks and 4 weeks before and 4 weeks following the implementation of the ASQ toolkit. Before the intervention, a total of 119 unique patient encounters were identified among the 7 providers who completed the educational program. Of the 119 patients seen, a total of 14 or 12% were screening for suicide risk. 4 weeks following the intervention, a total of 111 unique patient encounters were recorded. Of the 111 patients seen by providers who completed the educational program, a total of 93 or 84% were screening for suicide risk. So, information from the previous slide does indicate that suicide screening rate did increase. However, analysis of the data was needed to determine if the change was statistically significant. As previously noted in this presentation, a C-test of population proportions with an alpha value of 0.05 were to use this outcome. Included on this slide is a graphical representation of the difference in screening rate before and following project implementation, as well as the result of the C-test. The result of the C-test indicate that there was a statistically significant change in the screening rate following an educational program. The effect size was also tabulated and noted to be R equal 1, indicating the intervention had a large effect on the outcome. Example, suicide screening rates. So the result obtained from the project indicated that the screening rate increased from 12% to 84% post-intervention, and the change in screening rate was statistically significant while also having a large effect size. The results of this project do indicate that intervention was successful. However, the results were not surprising, especially in the light of the evidence base that was used to develop and implement this project in practice. First, there is an ample body of literature that supports the use of provider education regarding universal suicide screening to increase provider knowledge of the topic and to foster an increase in screening. So, universal suicide screening is recommended in the literature as evidence-based practice that should be used as part of the routine care. Based on the literature, the implementation of suicide screening program through provider education of a specific screening tool should foster a change in a practice that will be ensure patients receive care to identify suicide risks, such as the early intervention can be provided and life can be saved. So the primary strength of this project is that results align with what was anticipated based on the literature. Overall, the project demonstrates the veracity of making evidence-based change. Although action was needed to tailor the intervention to the practice utilizing the process of organizational analysis and translational science. It is obvious that the intervention not only follow the current evidence on the topic, but also produce results that were similar to what was seen in the literature. The results in the project definitely show that evidence-based intervention work, and evidence gained from base project can be further used to reinforce the evidence base. Also, the project resulted in an increase in suicide screening rates and reinforcement of the evidence base to support change. There are some notable limitations to the project, in particular, the methodology of the project, a single site, the pre-post intervention, the quasi-experimental design has significant weaknesses that do have implications for this project. Specifically, this type of design often uses a small sample for a single site, reducing, that's what happened, that design of a small sample, reducing the generalizability of the results. Additionally, quasi-experimental studies do not use true control group, which can make it difficult to show cause-effect relationship between the intervention and the outcomes. So, the implications of this project are considered. There is a relation to the future research and policy development. Future research for the project should include expanding the project at the practice site, expanding the project to other similar practice sites, comparing outcomes at different practice sites, and evaluating project outcomes over the long term. This action will help to strengthen the evidence to support practice change in terms of policies. It seems feasible to argue that the result should warrant a new policy at the practice site to ensure that all staff are educated about the ASQ toolkit and are able to use it. A policy mandating suicide screening for all patients may also be helpful. Over time, it is also anticipated that as more practice sites adopt this intervention, the evidence to support change will be codified through a state or national policy to include suicide screening at every patient care visit. This policy may also reimburse providers for utilizing this screening, which would be amazing. Okay, sustainability at the practice site will involve reviewing the result and surveying providers who participate to determine if any change needs to be made to improve the project. Once all needed changes have been made, the project will be sustained at the practice site by requiring all providers to complete a training on an annual basis. This will include a new hire. Additional dedicated resources for the project will be needed, including funding for a staff member to evaluate project outcome, assess changing the evidence base, and make recommendations for maintaining the project over a long term. Plans for dissemination of the work will include internal and external method at the practice site, a copy of the final DMP project, and an executive summary will be provided to all staff and leaders via email. Additionally, the project implementer will work with the leader to schedule a podium presentation, including a PowerPoint presentation that can be attended by all staff. External dissemination also of the work will occur through both a publication and a poster of presentation at a national conference. After reviewing the available journal for publication, the Journal of Psychiatry Mental Health Nursing was defined as a potential candidate for publication. Information from the published website indicates that the journal does public quality improvement project and is currently accepting submission. In addition to seeking publication of the work in a peer-reviewing journal, a poster presentation at a national conference will also be sought to be disseminated the work. In particular, to the American Psychiatric Nurse Association is hosting its 38th annual conference in Louisville, Kentucky, between October 9 to 12 in this year. Registration for conference is now open, and the conference accepts after and poster evidence-based practice of nursing or nursing research. For conclusion, the result from this project demonstrate that there is a compelling evidence to both sustaining the project at the practice site and to expand research on the topic to include a randomized controlled trial, pilot testing the intervention at other similar practice sites, and evaluating how provider and patient respond to the change over the long term. What is evident is that when action is taken to educate providers about universal suicide screening, this action works to improve screening and over the long term enhance outcome for patients. Although the results of this project are limited in terms of generalizability, the result provide a robust foundation upon which to sustain the project at the practice site, expand the project to the other practice site, and share this knowledge with other nurses and primary care providers so that systemic change with the healthcare system can be achieved. So before I'm leaving today, I want to take the opportunity to thank you all for reviewing this work with me, and thank you to my chairperson, Dr. Petrov. Thank you for everything you have done for me. Thank you. And here is my reference list, as you can see. Thank you again. Thank you for everything.